Hi, everybody. I think we'll get started. I want to welcome everyone to the Families in Context Primary Care webinar. In this webinar, the presenters are going to demonstrate how to deliver family-centered care using contextual interviews, brief interventions, and relationally focused shared decision-making within the primary care setting. But first, I would like to introduce today's presenters. First, Ruth Nutting, Ph.D. LCMFT, is Director of Behavioral Health at the Ascension Via Christi Family Medicine Residency and Clinical Assistant Professor at the University of Kansas School of Medicine, Wichita. And in these roles, she trains family medicine residents in behavioral health, facilitates resident and faculty wellness initiatives, and oversees the functioning and sustainability of the integrated behavioral health program. Dr. Nutting's passions include advocating for trauma-informed care, expanding behavioral health integration in primary care, and encouraging healthy behaviors for patients and physicians. Deepu George, Ph.D. LMFT, is an associate professor of family medicine and serves as the lead for primary behavioral health integration at the University of Texas Rio Grande Valley School of Medicine. Areas of interest for him include PCBH-focused workforce development for primary care physicians and mental health learners, physician well-being, and operational aspects of PCBH implementation. Randall Reitz, Ph.D. LMFT, is the Director of Behavioral Medicine at St. Mary's Family Medicine Residency in Grand Junction, Colorado. He leads a doctoral fellowship in family medicine education and a postmaster's internship in medical family therapy. Areas of interest for him include behavioral medicine mentorship, narrative medicine, and primary care behavioral health services. And Maria Jesus Chus Arrojo, MA CGAS LMFT LMHC, is the Behavioral Health Integration Manager at the Pediatric Physicians Organization of Children's, PPOC, in the Western Massachusetts region. She oversees the region's integration programs of the independently owned pediatric practices affiliated to Boston Children's Hospital. Areas of interest for her include systemic approaches to integrated care at clinical, educational, organizational, and community levels. At this point, I'll turn it over to the presenters.
Thank you so much, Jessica. That was Jessica Goodman, the chair-elect of the Families and Health Special Interest Group. So from here, we will identify our overall objectives today. There we go. All righty. So we have 5 primary objectives today. Our first will be providing a background of family-centered assessment and intervention. Chus will kick us off with that. From there, I'll review a pertinent case study. Deepu will then demonstrate a contextual interview as applied to family-centered primary care. I will follow that up with identifying brief systemic interventions related to that contextual interview. And then lastly, Randall will be discussing relationally focused shared decision-making in the primary care setting. So Chus, would you like to tell us about the background?
Sure. The Institute for Patient and Family-Centered Care defines family-centered care as mutually beneficial partnerships between healthcare providers, patients, and families in the planning, delivery, and evaluation of healthcare. In its broadest scope, the notion of family-centered care embraces the view of the care client as the patient and their family rather than just the patient. Given that patients and their families are the people who actually experience care, their perspectives on that experience can really contribute to an effective and efficient healthcare design and delivery. A universal goal of family-centered care models is to develop and implement patient care plans within the context of families. To facilitate the goal, family-centered care models require collaboration between family members and healthcare providers, consideration of family contexts, and education for patients, families, and providers, as well as dedicated policies and procedures. Eliciting families' perspectives regarding priorities and abilities to provide care will contribute to more informed and better defined outcomes, as well as enhance families' abilities to support the plan and optimize patient outcomes. Family-centered interventions that accommodate the ecologies of families and empower families in the process seem fundamental. The need for a methodology for assessing strengths across families and cultures has been identified as an area for further development in the family-centered care literature. Shared decision-making promotes family and clinician collaboration with ultimate goals of improved health and satisfaction. It is recommended that providers employ high-quality, reliable tools and skills for informed shared decision-making with patients and families that are tailored to clinical needs, patient goals, social circumstances, and the degree of control patients prefer. It is also recommended that enhanced communication tools and decision aids are customized to family circumstances, especially to health literacy. Informed shared decision-making involves patient, family, and provider education.
Excellent, thank you. So now I'm going to provide an overview of our patients that Deepu will be utilizing in regards to the contextual interview. So our family composition is a young adult heterogeneous couple. Our male partner is named James. He is 42 years old. And our female partner is named Bridgette, and she is 41 years old. So Randall has gone ahead and shared this case study for you for your review. And so you can access that within the chat as I review this. So James is establishing care with his new primary care physician, and he is primarily here at his appointment to discuss refills of medication. He has historic diagnoses of both alcohol use disorder to a moderate degree and post-traumatic stress disorder. Current medications that he is taking are sertraline, 50 milligrams per day, as well as Xanax as needed. Today, his current mental and emotional status is indicated on the PHQ-9, so the patient health questionnaire, as scoring a 14 for moderate symptoms of depression, and the generalized anxiety disorder score is a 12, also indicating moderate symptoms of anxiety. He is indicating no suicidal or homicidal ideation at this time. Socially speaking, James is a certified electrician. He reports that he is currently averaging 50 or more hours of work each week. He notes that much of his free time involves drinking. When asked how much he drinks, he indicates 5 to 6 12-ounce beers per evening and an average of 16 to 20 beers over the weekends. James indicates that this pattern of drinking has developed over time. He notes that in high school, he was a star athlete, heading to college on a full scholarship. This was until James was involved in a motor vehicle accident in which 2 of his passengers were killed and he received a DUI. He notes that he continues to experience flashbacks and nightmares related to the accident. James states that he avoids distressing memories as well as the location of the accident. He also endorses persistent guilt and a lack of positive emotions. Biologically, he has a history of alcohol disorder, as we discussed. Recent tests indicate that his liver functioning has decreased. James reports that he has not changed his drinking habits, and he presents as indifferent to making changes to his drinking patterns. Second, there is a diagnosis of post-traumatic stress disorder. Symptoms have been consistent over the past several years. James believes his medications are effective, particularly the Xanax. He has attended psychotherapy in the past. So family history, his father is obese, mother also has anxiety, and he is of Caucasian ancestry. So Bridgette is also here to establish care with her primary care physician and to discuss refills of medications. Her primary diagnosis at this time is type 2 diabetes mellitus, and she is currently taking metformin 500 milligrams with breakfast as well as 500 milligrams with dinner. And her current patient health questionnaire score is a 3, so very minimal symptoms of depression. Socially speaking, Bridgette is a medical assistant at a local clinic. She reports enjoying her job and is contemplating and enrolling in a nursing program at a nearby college. She would like to complete her nursing degree prior to turning 45. Bridgette reports that she has loved James since 8th grade. She notes that James is a victim of his circumstances and that she remains dedicated to him and their marriage. Bridgette identifies that she is increasingly concerned about James's drinking habits and feels that there is emotional disconnect in their marriage. Bridgette states that she recognizes herself as an emotional eater. She identified that her father is the same way and that she developed this coping behavior at 12 years when her mother died. She notes that she is concerned about her increased weight gain and recent diagnosis of type 2 diabetes mellitus. So biologically speaking, diabetes type 2 mellitus is her presenting concern. Her last A1C score was a 7.5. Bridgette is aware that if she makes certain lifestyle changes, she can decrease her A1C to a pre-diabetes range or better. She follows through with taking the metformin as prescribed. To date, she's not made any lifestyle changes. Family history, her father has type 2 diabetes mellitus as well. Her mother died at the age of 42 with metastatic breast cancer, and she is of Latinx ancestry. All right, Deepu, so would you like to inform us on the contextual interview?
Sure, absolutely. All right, so engaging a family in a primary care visit room, just to think about the dynamics of that, right? I think most of you are familiar with this, but we'll go over it. One is to get consent from the patient and kind of use the patient to introduce others in the room. This kind of gives us a sense of the relationships and other things instead of us having to make assumptions. And then if there are people across the lifespan, making sure that you kind of address that and kind of engage them as you go through the different phases of your work with the family. Maintain eye contact with all individuals. If you kind of think back to your contextual family therapy roots, Naj talks about multi-directed partiality. That's kind of what is at operation here when you kind of engage multiple members of the system. And respect any social locations and how they may impact engagement as you kind of work with the patients, right? Next slide. So focusing on PCBH and kind of bringing in the family context. So one of the big components of a PCBH focused interview, especially as kind of designed by Dr. Strassel and Robinson, is what they call the contextual interview. Contextual interview is essentially understanding the patient and family in context, so that the intervention that we developed is based on a collective understanding of what's going on. So like the basic kind of idea there is, if you don't have a clear sense of how the patient's life looks like or the family's life looks like in a typical day, we probably have no business in kind of like really prescribing things for them to do, right? So what is the context of the behaviors in which the things that we're trying to fix? So we can then kind of say, what would be the uptake of some of the things that we suggest to them? Is it appropriate for them? And does the context match the interventions? Do they have the time, the motivation, the energy to kind of carry these things through? So the next slide, Ruth, please. Thank you. So the contextual interview, you can sort of break it up into two kind of sections. We can call it like the context related questions and then the problem related questions. We'll get to that in a second. In the contextual interview, we want to get access to 4 pillars, right? Remember, this is also the context in primary care. So we want to get just enough information to kind of get a snapshot so that we can begin to intervene using those contextual variables, right? So first thing that we check is love, essentially relationships and the things that they're involved in on a daily basis. It's essentially who lives at home, where do you live, how long have you been living there, kind of helps you understand stability, transitions, etc. And then you can ask like quality of relationships and satisfaction with the relationships that they have at home. You can kind of use this scaling question if that would be helpful. Where do you work? So kind of getting a sense of what is their professional life or life outside of like their home look like? How do they get their financial needs met? So if they're not a full-time student or working, that could be potential risks, right? In terms of connection to resources or lack of resources. Place, essentially, what activities do you do as a family? Or really the question is, what kind of things do you do that gives you a sense of enjoyment, relaxation, and kind of shutting down, for the lack of a better word, right? It's like, Are you engaged in routine activities that take care of you? And so low activities in the play area can indicate kind of disengagement from one of the vital areas that can give people a way to kind of handle the different things that they're going through. And health is really illnesses that are present in the family, and how does the family take care of it together. And if it's on an individual basis, you kind of ask about tobacco, caffeine, alcohol, drugs, any other over-the-counter medications or supplements that they may be taking, in physical activity that they do together, right? So that's kind of like the context of that. And then the next slide, we will kind of look at what we call the problem context. Essentially, we're really looking at onset, triggers, and course of the illness, right? So in terms of like putting it into a couple family kind of context, we kind of can think about it from a circular question kind of perspective, so we can draw the dynamics out a little bit more. So time trigger trajectory is essentially, when did it start? What are the different things that tend to trigger it? What makes it better? What makes it worse? Since it started, has it been the same, better, or worse? Why is it important to seek help now? How important is it for you to kind of address the kinds of things that you're dealing with, right? So you would kind of see a couple of the questions that I would eventually ask the couple that we'll deal with. So that's like kind of the second part of that interview, if you will. You're kind of gathering the full context. So you kind of get a sense of the life context that the patient and the family is living in, and then you kind of get a problem context of what they're kind of going through. So I think what we'll do now is kind of like jump into the role play. I'll meet Bridgette and James and kind of go from there. I have about 9 minutes left, so I'll stop at 9 minutes and then kind of let Ruth carry on with the intervention, but wanted to give you a sense of how this may look in a conversation. So you guys ready? Bridgette and James?
Mm-hmm.
All right. Hi, good afternoon, Bridgette and James. My name is Dr. George, and I am a behavioral health consultant. I am a family therapist by training, and in my role here at the clinic, my main job is to make sure that our patients are moving towards their best health. I work very closely with Dr. Smith, your primary care physician, and you can see that this is the medical chart that he uses, and I use the same medical chart as part of my documentation. We stay in touch just as part of good healthcare that we deliver to you. Part of that also involves us paying attention to your habits, thoughts, emotions, stressors, and maybe in how a relationship may be affecting your overall health and quality of life. So we're going to spend about 15 to 20 minutes together to get a good sense of what's going on and come up with a plan to sort of help you guys address some of the things that you want to address today. That often looks like teaching you a new skill, giving you some self-management resources and things that you can access outside of our visit. Some patients and couples that they see me, they get what they need out of a single visit. Some patients come back for multiple visits based on what you think would be helpful. Everything that you tell me is confidential. The only time you break confidentiality and bring other people in is if there's any immediate sense of threat to yourself or somebody else. That's kind of like the usual spiel that I give patients. Do you have any questions from that?
No, that sounds good.
Sounds good. Thanks, James. Bridgette, any questions from that?
No, thank you for explaining that. Yeah, it sounds really good.
Okay, all right. I'm glad you guys are on board. I know Dr. Smith talked to me a little bit about different things you guys are establishing with us. It sounded like one, if we can kind of get you guys thinking about more behaviors to kind of help you get more active, but also address some of the where you guys are as a couple to increase like intimacy and quality of your relationship. Is that what we can stay focused on?
That's fine.
Sure.
Okay, all right. Let me get to know you guys a little bit. Where do you guys live, and how long have you guys lived here?
James, do you want to say?
Oh, we've been here for many years, most of our lives. We've been together since we were kids, pretty much.
Okay, yeah. So this is like a familiar area for both of you, it sounds like, right? And And Bridgette, who all are at home with you guys?
Just the two of us.
It's just the two of you. Okay. And you guys have been together a long time.
Yes.
Let me ask you this question. I'm going to ask you to kind of think about numbers here a little bit. On a scale of 1 to 10, 10 being if you're really satisfied and I'm comfortable, 1 like not satisfied at all, there's a lot that we can improve. Where would you kind of rate the quality of your relationships right now that you have with each other? Bridgette, where do you think you are?
I say I'm at a 5 right now.
5. Okay, so like somewhere in between. And James, what about for you?
You know, about a 6 or a 5. You know, we've been together a long time, and you know, like we know each other quite well, but that can be good and bad, right?
Yeah, it has its effective and non-effective sides. If you guys want to move forward, where would be a good number to be at?
Oh, I wish we could go back to an 8.
An 8, okay. What about you, James?
Sure, 8 sounds good.
8 sounds good. Okay, so we kind of keep that in the back of our mind. And I understand both of you are working. James, how long have you been working as an electrician?
You know, it's been a good career for me across the years. It's, you know, it's been something that I've done for quite some time. I've worked my way up through the company.
Okay, and good relationships at work. You enjoy the work that you're doing?
Yeah, overall, it's quite good. I can't complain about work.
All right. And Bridgette, it sounds like you're really excited about your current role and you want to do some stuff in the future with that. Overall, your quality of work and things that you enjoy at work, would you say it's going well, or are there stressors that you face there?
Oh, it's going great. I love my job.
Okay,
I have no
good.
issues with it. Yeah.
All right.
You know,
good.
Bridgette
So,
would probably say I work too much, I guess. I'm putting in, you know, 50 hours a week or more, but it's what you do if you're trying to move up in the company.
Right.
Okay.
Yeah, that's true.
All right. Well, maybe there's some place that we may address that a little later. Thank you for telling me that. Tell me a little bit about what do you guys typically do individually or as a couple to relax or calm down or have a sense of fun or relaxation?
You know, I hang out with my friends. We do some stuff together. You know, you know, our weekends like to get together with some friends and have a few beers.
Okay. So that's what you, and what about you, Bridgette?
I like going to the movies. That's my favorite thing to do when I'm not working.
Okay. So,
Yeah,
so
but
movies.
yeah, James, you're forgetting that you love fishing too, and that you do that as well.
I do love fishing, and that's something that Bridgette and I do together sometimes.
Okay. When's the last time you guys were able to do fishing and kind of be together to experience that?
It's been a while.
Yeah, it's been a while.
It's been a while, right? Okay.
Too
So I
long.
think it's, yeah. All right. So let's sort of begin to think a little bit about, I know you guys have different health concerns that you talked to your PCPs today about. And I know one of the things that we want to focus on is just like the emotional connection between the both of you. Tell me a little bit about, Bridgette, like when did you notice that the sense of connection was kind of beginning to miss for you?
Oh, well, I think it has been happening for a while and increasingly so. So it's hard to point, you know, the finger on when exactly it started, except for this traumatic thing that happened to him a while ago.
Sure.
Since then, it just went up and up. Yeah.
Okay, so it's been happening for a while, it sounds like. Bridgette, when do you remember, even after the kind of the incident, James kind of seeming less connected in the more recent past?
Oh, I say that during the last 6 months, it got even worse.
It's got, okay.
Yeah.
James, I'm curious if you could take Bridgette's perspective for a second. What would you say, what do you think she means when she says she seems less connected or you seem less connected?
Oh, she always brings up my drinking. I don't, you know, it's not a big problem to me, but I know it is to her.
Okay, so it sounds like there's some differences of opinion there, right? Has anybody else commented on anything that's happening in your relationship?
Well, for sure, they comment on the drinking, even though he doesn't see that as a problem. Other people have told us, my family, for instance.
Okay. So there's some external observations. As you think about, does the drinking kind of take you away from Bridgette, do you feel like, James?
Yeah, I mean, it takes me away from lots of stuff for sure. You know, as you
Okay.
mentioned, I had this accident several years ago, and ever since then, I haven't felt the same. And
Okay.
you know, I don't sleep well anymore, and wake up with nightmares, and it's just the thing I can do to get by these days.
Yeah, it's kind of like one way to kind of get through all of those, right? So when these things are happening, Bridgette, what are you experiencing as he kind of is dealing with all of this?
I don't know. I just feel like he's not there. You know, he's there, but he's not.
Yeah.
That feels bad.
Because of these things have been kind of happening, would you say your relationship over the last couple of months has gotten better, worse, or like it's kind of remained the same?
I think it's gotten worse. I think you know, she's harping on me quite a bit, and so it makes me want to just pull back even more. You know, why
Okay.
should I go home and talk to her if I'm just going to get, you know, a lecture?
Yeah. In the past couple of months, even when things have been bad, has there been any moments when things have actually that you guys were able to do that gave you a sense that it's going in the right direction?
Yeah, actually, I just remember I said before that it's been a while since we don't go fishing. I mean, we
Okay.
went fishing together recently, and I love that because that's kind of a time that we spend together, that we have fun. Do you remember,
Okay.
James?
I do. You caught that
Okay.
big bass.
Mm-hmm.
That's right. Okay. All right. Well, time out. I'll stop there because it's time, but we would probably build a little bit more on that. And I think one of the questions that I would ask is on a scale of 0 to 10, how important would it be for them to kind of work on this? Because there is a lot of things that they're dealing with. And if their motivation is high enough, then we can kind of make that a priority. So the things that we kind of found out is like the home environment. We know that Bridgette's family is involved. We didn't really check on social relationships in this short interview, but that's one of the other things that we would probably think about in terms of their play factor. What do they do as a couple? That, if you really think about most of the things, that's where a lot of the intervention points can come. And then we began to focus on the quality of their relationships.
Excellent. Thank you, Deepu. So we now have a solid picture of James's and Bridgette's context. So now that we have identified really, you know, what their triggers are, what the timeline has been like, and what the projection has been like, we can start to focus in on intervention. And so we want to make sure that our interventions are pertinent to the contextual factors. And so by having this picture, we've been able to identify their values. So we know that when they are spending time together, they are happy. That's when we're seeing behaviors that are more positive. So for example, James is drinking less. And in the emotional realm, they're feeling more connected, they're more engaged. So we can really focus our interventions on values, behaviors, or emotions. So in the next slide, I'm going to review what brief systemic intervention looks like and how to do that well and how to be very collaborative in that process. So with brief systemic interventions, we want to make sure that we're setting goals our patients agree upon. Otherwise, they're not going to follow through on those goals. These goals have to be very patient-centered. They also have to be specific, measurable, attainable, realistic, and relevant, as well as time-bound, which we'll talk about in a little bit. Again, these goals need to be informed by contextual factors and influencers, and we want them to be realistic so that there's rapid improvement in functioning. So at this time, we're going to invite James and Bridgette back, and they are going to walk through an intervention with me. So we are going to identify a goal that is going to help improve their overall functioning. So James and Bridgette, welcome back. Thank you. So in listening to that contextual interview, it's very clear that the two of you enjoy spending time together. Would you agree?
Yeah,
Yes.
some things for sure.
Okay. And it seems like there potentially may be less of that currently. It seems, James, you're working a lot. Your career is very important to you. Bridgette, your career is also important to you. But it sounds like maybe the two of you are not joining in on shared activities as much. Is that accurate?
Yeah, I think you're right.
Okay.
Yeah.
Okay. So there's been a little bit decreased quality time. What are your thoughts on focusing on increasing that quality time together?
I would love to have back the girl I knew in high school for sure. She was a sweet woman.
Okay.
Yeah, I agree. Mhm.
Okay. All right. So it sounds like the two of you are both in agreement that you want to focus more on each other and the experiences you have. So what could the initial goal is to increase engagement or quality time. What will you do to increase quality time together?
I mean, I appreciate when she goes fishing with me. I know it's not her favorite thing to do, but she definitely comes along and she'll cast a few times, or she'll read her book alongside me, and it's nice to get away, especially now that it's springtime. It's been a pretty long winter. And I know she loves eating out. We have a different taste in food, but I do enjoy going to restaurants with her.
Enjoy having dinner together. Are there any other activities that you enjoy, Bridgette?
No, well, yeah, we also like going to the gym or doing some sports together. But I think the fishing is the thing that I connect with him the most. Yeah.
Okay, so you're going to incorporate fishing time together. All right. When and how often do you want to go fishing together?
What do you think, James?
I mean, I'd fish every weekend, of course, but I know it's something that we have to work in when we can. If we could go even twice a month, that'd be nice.
Yeah, that sounds good.
So realistic goal is every other week at this point?
Mm-hmm.
Excellent. Okay. Anything you need to do first to prepare for this time together?
I mean, I like taking care of my gear. A man has to have a good tackle box, and so I have to go to the store once in a while. Okay. Afterwards, clean up my box a little bit. One of us has to make lunches, and I can do that sometimes. What else do you think, Bridgette?
Well, of course, his gear includes his beer, so we should be careful of how much beer he puts in there to go fishing together.
Okay. All right. So I'm hearing a couple of things. I'm hearing that, James, you're going to focus on making sure you have the supplies you need. The two of you will maybe share in preparing a lunch to take as well. And then, Bridgette, it sounds like I'm hearing a challenge that could arise. You mentioned the beer. Can you say more about that?
Yeah, I mean, if he brings 20 beers to the fishing,
20 beers.
We have to make sure that he doesn't do that. Otherwise, he can drink when he's fishing too. So
okay, so
I would have to put a limit on that, right?
Okay, so excessive amounts of beer could be a point of contention. James, what are you thinking? What are you feeling right now in regards to that comment?
I think 20 beers I've never taken 20 beers drinking before, fishing before. Maybe on a weekend one time, but not like fishing.
Okay. Bridgette, how many beers would you be comfortable with James or the two of you having?
No, I'm fine if he brings 3.
Okay. All right, so 3 beers. Does that seem realistic for you, James?
Yeah, sometimes I don't drink any at all. I can drink 3.
Okay. So we also, whenever we're establishing any goal, we also want to make sure that the two of you are rewarding yourselves for following through with that goal. So when would you like to reward yourself? Some people like to reward themselves after a month of following through with the goal, sometimes maybe after 6 weeks. What are your thoughts?
I don't know. I'm having a hard time understanding that, but what do you think, James?
I mean, fishing is its own reward, so I don't know what you need.
Okay. And so maybe really establishing this as your pattern of spending time together will be a continued behavior, and that will be rewarding in and of itself.
Yeah, and obviously, we could go out for dinner afterwards. Probably want to take a shower first, but.
Okay.
Well,
Sure.
that's a good idea. Now I understand it. Yeah.
Okay. So maybe if you follow through with this, you'll also be very intentional to reward yourselves by going to dinner after you've spent time together and enjoyed an afternoon of activities.
Baby loves Olive Garden. Those breadsticks.
All right. Okay. Excellent. Thank you both. So to recap, James and Bridgette have set a goal of spending time together engaging in fishing. They're going to do that bi-weekly. James is going to prepare by making sure he has the materials and supplies that he needs. They've both agreed that James will not be drinking more than 3 beers during that time together. And so that's really handling that challenge well and being mindful of what challenges could arise if he were drinking more. And they'll reward themselves by following through with this activity, as well as incorporating dinner afterwards. All right, so now Randall is going to talk about relationally focused shared decision-making.
All right, so you can tell we're doing just some bread and butter topics here of, the basic of contextual interviewing, the basics of behavioral interventions for families and relationships, and then looking at the basics of shared decision-making and how we can apply those to families and couples. If you could advance a slide, please. So we look at shared decision-making is something that's been around for quite a while, enough that we have a number of good systematic reviews and RCTs. And so the Cochrane review is the gold standard of how do you look at it? Is there enough support to say this is an evidence-based practice? And so there's a 2017 Cochrane review that found that there's a number of things. Please advance through them. Increasing patient knowledge, patients feel more informed, decisions are more values congruent, a decreased patient passivity, improved patient-provider communication, and reduced major surgeries. And so these are all good goals for shared decision-making. So what is the shared decision-making? Please go forward. So there's kind of different ways of making decisions in primary care and healthcare. A paternalistic approach would be kind of the provider saying, here's what you should be doing, making recommendations directly. An informed medical decision-making approach is trying to give the person enough information they can make a decision. And then the shared decision-making kind of brings both those together. So we're going to have an evidence-based practice recommended by a physician, but within a menu of options. We're going to have an informed patient. So they're able to be the one to make the final decision in a way where they feel like they can, based on their values, based on what's best for them, based on their means, can make a decision to go forward. And we believe that really results in optimal patient care. Please advance. So there's ethical considerations for when we do this with families and couples as opposed to just an individual. With older adults, there's a tendency to often view family as either allies or aggressors. I think we've all seen families where there's often an adult child who's helping out with the parent. And sometimes it goes very well. And I think as a system, we rely on families to do this role. The healthcare system couldn't even sustain the cost if we had to have every family bring in paid caregivers. And so there is this sense of this is a noble thing people do. It's what's best for us. But we also have adult protective services where there are situations where someone is being taken advantage of. And so you want to make sure that you're gauging the situation at home to figure out, is this where we have a strong ally, or is this where we have someone who we need to be careful with and try to prioritize the autonomy of the individual? Please advance. Similarly, with couples, there's going to be often will be an inherent power imbalance. And this is on a continuum, with just persuasion, meaning one person will try to persuade the other person in a way that's open, candid, transparent, and ideally balanced. Manipulation would be where you feel like there might be someone who is not playing straight with you, who might be trying to serve their own needs more than the other person's needs. And there could be coercion where there's, use of power directly to get what you're wanting. please advance the slides. So on one end, both partners make decisions wholly independently. They're living kind of in this semi-independent realm. Often they've been together enough that they might have either complete trust or a little trust, and so it looks like it's very independent. I think the second circle represents where I would want things to be. Both partners are equal and support each other in making healthcare decisions. And you move forward through this to become more dominant, whereas the end one is the dominant partner makes decisions without involving the other. It might include threats or violence. And so always just taking this into account of, what is the power balance? How much autonomy do we have here? How do I make sure that the patient who's scheduled with me today is given a sense of primacy, but also including the other person as appropriate in their care? Please advance. Looking at working with children with disabilities, there's very similarly this idea of who's in charge of the care. And on this top box, is it the family is responsible for the final decision versus the physician's responsible for the final decision, or are there different gradations within that? And shared decision making is kind of in the middle. And this group recommends the idea of choice talk, options talk, and decisions talk. And so choice talk is just kind of introducing what are the choices available to us today, what could be done. Options talk would be looking like, let's look at each of those things in a way that unpacks them so we understand the pros and cons, any costs and implications for the patient and the family. And then decisions talk is where you actually kind of make a decision, guiding the patients to make their own decision. And in this way, you can focus mostly on autonomy specifically, which would be kind of a consumerism model, or beneficence, which is more paternalism, and then bringing them together into shared decision making. Please advance. So here are 4 principles for relationally focused shared decision making that I pulled together. The first one is the patient decides who is involved in the decision. And I'd recommend having at least one discussion with the patient alone, just so you can engage, is how I'm reading the room accurate to the patient? Do they feel like they can speak freely? Do they have any concerns about me involving their family? Is it a safe environment? 2, discuss the many possible approaches and levels. That's part of the decision talk, the understanding what choices are available. The patient has ultimate say. And that's generally true in our American healthcare system, that the patient who is on the schedule, who has their insurance, who is being seen that day, should have the final say. Exceptions for that would be if the patient's underage or if they're not decisional based on dementia or some other reason. And then the fourth one would be always check in on caregiver burden. How is the caregiver holding up under the duresses of providing care if there is a caregiving situation? Like with James and Bridgette, it's not really a caregiving, it's more of an equally yoked situation, but often there is going to be a parent who's going to be taking care of a child, a well spouse taking care of a more sick spouse, or a child taking care of an older adult. So just kind of 4 principles of how you can balance the relational focus with the individual focus of shared decision making. Please advance. Let's go back to the role play. So since I'm going to be the clinician now, we'll have Deepu step in for James. Okay, well, good. So we've been talking about how to bring the couple back together, how to help you to get along better, and especially share some more pleasant memories. You both have expressed that you felt like you were more intimate before, more close before, and that recently things have been more separate because of work, because of stresses, because of being together for so long, and also because of the drinking that James does. So I wanted to take just a few minutes today to talk directly with James about the alcohol and see what we might do, if anything, about that. So James, can you tell me about your thoughts about alcohol and drinking, and are you drinking at a level that you're comfortable with, or is there anything you would change?
Well, I'm definitely comfortable with it, right? Because I think it's been, it's one of the things that I go to, especially when things get really tough, I think. And I can see other people's concern. and I know my liver functioning, or the doctor told me something about that. So yeah, I'm comfortable, but I also know it's not good in the long run.
Yeah. And you mentioned before that one of the reasons that you drink is because you have difficulty sleeping and you have had this horrible car accident that still impacts you. Other things that you do that might help with that anxiety, that struggle?
Things like taking medications or some other kind of
medications,
activity.
or for anything help you with sleep, or with to kind of take the edge off of your life without needing alcohol?
Well, I know Bridgette mentioned a little bit about exercise. There are a few times when I am able to, play basketball or kind of do something with a group of my friends, and that usually, those nights are a little bit easier to fall asleep because I'm more tired physically.
So you have noticed that when you're physically active during the day, the edge comes off a little bit more naturally, and it's easier not to do edge drink.
Yeah, schedule-wise, I think, because of the work schedule, I noticed that it just happens randomly, so it's not very consistent.
Yeah. I'm curious about a time when maybe for a few days you weren't relying on alcohol as much as other things. Has that happened recently?
So one is definitely that. I know Bridgette said she likes to watch movies, as long as it's not chick flicks. If we could do something more neutral. I think we've done that actually a couple of times, like with all the Marvel stuff coming out. I think we were able to watch that together. I think that was fun.
That's good. Very good. Bridgette, your thoughts? I know you've been with James for a long time. When was the time when you were feeling more comfortable with him and with the place of alcohol in his life?
I think any time we took a vacation together, it's the same feeling that with the fishing, right? Is having time off our regular day. That seems to be better for him too, not only because I feel better around him when he's, different, but also I feel him more relaxed and feeling better.
Yeah. I mean, what I hear you both saying is that when you two are together doing activities that you enjoy, that in itself is a deterrent for him wanting to drink.
Yeah, I would say that.
Yeah, I would agree with that.
So Bridgette, let me ask you a question. I'm going to ask this question of you, but it's about James. And that is, if we were to ask James about when it is that being with you helps him to relax and be more himself, and when is it that has the opposite effect, that it maybe increases anxiety or increases his sense of isolation? What's the difference there, do you think? What would he say?
Again, if he is doing his routine and I'm doing mine, I think I might be on him more for the drinking also. Like it bothers me, that I see him disconnected and drinking as if he were not living with me. And I feel that when we are doing something special, we both are looking at each other about, what are we doing, where are we going, and just disconnecting from the routines that are not fun or special.
What I hear you both saying is that you like it when we're together for like a special activities where we're going out of our way to pay attention to each other and to meet the other person's needs, whether it's a movie or dinner or fishing. When it's more mundane day to day, especially when you're under the pressure of alcohol or of you challenging when the alcohol, is when it's less positive.
Yeah,
Correct.
I think that's right on, Bridge.
Yeah. James, what was it like for you to hear her describe that about what it's like to be with you and what she likes about being with you still?
I didn't quite notice that, but I do experience that now that I recall it. as she's talking about it.
Yeah.
So I didn't know that we were essentially kind of planning things that kind of took me away from drinking.
Yeah. Okay. Is that okay for you?
If it's, yeah, it seems to be working. It was just that's happening and I didn't know.
Yeah. Well, if you were to set a goal for yourself as to kind of adjusting a little bit the place of alcohol in your life, you know, is there a limit or a place that you would say, yeah, maybe this much alcohol, but not more than that, or times for alcohol, but also times where there wouldn't be alcohol involved?
I think fishing for sure, 1 or 2 beers is like part of the gear, as Bridgette said. But I think if you're kind of planning activities and I know that there's something that we can look forward to, I feel like those are moments when I don't have to kind of bring alcohol with me. And I think limits is something that I know I have a different opinion on. Bridgette has one too, so we can kind of maybe discuss that at home and kind of come up with a plan there.
Okay, very good. Let me just summarize what I've heard you all saying. A couple of things. One is you enjoy being together, especially when it's a special time where you're going out of your way to pay attention to the person. You both have some concerns about alcohol, especially during that couple time. And you both have this sense of when you're being together, when you're taking care of each other, it takes the pressure off of James wanting to drink, and that you're both wanting to do more of those activities moving forward. Does that sound about right?
That sounds right.
Okay. All right, I'll stop there with the role play.
Thank you all. So at this time, we want to turn it over to participants and answer any questions that may have come up for you throughout this presentation. And you can certainly unmute yourself, or you can also type the questions in the chat box, and I'm happy to read them from there.
I appreciated the role play and sharing your expertise. I guess when I hear these, I'm always trying to imagine what does the paperwork look like? And I'm from Maine, and in our system, the paperwork is quite cumbersome. And so when you showed some of these visuals, is that what some of your documentation actually looks like?
So I can answer in regards to the brief intervention. And we actually, so that brief intervention format I have copied, and I write in patients' goals within that format, and I provide that to them to take home and place someplace where they can see it and visualize it. And then within our EMR, I actually do have a dot phrase created with that outline, and I just go in and I complete that outline. So yes, for the brief intervention. Deepu, do you want to talk about the contextual interview?
Sure, yeah. The contextual interview is actually built into our template. So we have love, work, play, kind of like, it could also be a dot phrase if you want to be, but the way we built out our template is that we also have a question that assesses the level of importance of how they want to rate their current thing, whether it's couples work or alcohol or health behavior change. And it does go through this time trigger trajectory kind of set of questions. So that's built into the EMR. And then there's a, objective assessment plan kind of sections as well.
Do you teach this to the physicians as well, or are these skills just being done by the behavioral health professionals?
Yeah, at I'll take that one. At our program, we do, a very intensive second year training for residents where, the family focused primary care is a big part of that. And just teaching these basic skills, things that would take 4 to 5 minutes to do, relevant in a primary care setting. And so we would probably do, encourage them to do one of these things in an appointment, not all 3 of them. And so have them demonstrate a contextual interview, have them demonstrate this family brief interventions, have them demonstrate how do you include family and partners in shared decision making. I think that they love it because I think it's, especially like in the hospital setting, they feel very much kind of at wits about how do I deal with these families and how do I feel I have a sense of control in the room. And by having them use these skills directly gives them a sense of control again.
And also in regards to the brief intervention, that is definitely a technique and skill that is taught to the 54 family medicine residents at my site in Wichita, Kansas. They get taught that throughout didactics as well as on their behavioral health rotation, and they are encouraged to use that same format when collaboratively setting goals with patients. Other questions? There was a good question that was sent privately to me, but I think it would be great to answer this question collectively. And Deepu, I think that this will be best for you to answer. So Lisa Tyndall asked, whose record does this note go in? And what is the consent process like for the person whose record is going in?
Yeah, so the consent process is in the initial introduction, like the patients say they don't wish to continue, then we don't move forward. And the identified patient, whoever the PCP refers to, becomes the patient. And then we chart the discussion and the plan in that medical record for them as a couple. And so the target problem is a couple related issue, and we chart it in that.
So I appreciate that. I guess I'm getting hung up on. So if information about the person whose record it is not is then included in the person in the record. I mean, I'm just always thinking worst case scenario, which is terrible, but like, you know, in terms of asking for records, or who does that record then belong to? If it does it, I feel like we used to always talk about it as like the person who's in the session, but who's not the IP is kind of a consultant. And it's not really like there's a clear understanding that that record does not really belong to them, and that I don't know. I'm trying to help people get really, when I try to introduce family ideas into integrated care clinics in North Carolina, I feel for people who are not used to that idea, I feel like they get really hung up on. I mean, obviously I'm getting hung up on it just for liability's sake. And I want to have a clear answer. And sometimes if their system is already having trouble introducing behavioral health, it's like one more hurdle to introduce a relational concept. I just don't feel like I have a good answer for them yet.
I would say, I think the thing that I rely on, or at least one, is in primary care, your notes shouldn't look like what it looks like in specialty mental health, right? So I always think of who is my stimulus equivalent? It's actually the PCP. So to what extent would they describe certain things? Do you want to get into a lot of the details? You're really outlining onset, course, and time, and triggers, and those kinds of things. And you're not gonna, I'll never put highly sensitive information into the record, because as part of team-based care, we just want to know what was done, what is to be expected, and what is a patient expected to kind of come back with, right? It's like they had this headache, I'm going to start them on this, we're going to wait 4 weeks and see how they respond to that. Same thing here. Couple wanted to enhance their communication. We started them on these behavioral experiments. Let's see what happens in a few weeks.
Okay. So am I hearing you correctly when you say like the level of information recorded in the note, even though it's a couple's note, is still kind of keeping at that, the non-analysis piece of it. So it becomes less sort of,
right.
Like, okay.
Yeah. The analogy would be, what do PCPs expect?
Right.
And what could, like, if I go a lot of like family systems analysis in my note, it is unlike what a PCP would do. So then I'm suddenly introducing in my note writing a component of specialty mental health in a primary care context. And that shouldn't be the case.
Right. Okay, great. Thank you. Sorry.
I want to be mindful of time. It is 1 minute after the hour. I'm certainly happy to stay on if anyone else does have any further questions at this time. All right, well, thank you all. And I did also want to advance through as well. This is the presenter information if anyone would like to contact us at any point in time. And I'll leave that slide up for a couple more minutes so that you can get those email addresses.
Thank you for coming.